there are two types of barriers. The first one is a knowledge barrier, and second one is treatment barrier. So what is the knowledge barrier? Knowledge barrier is based on the fact that we cannot do gene therapy unless we identify the genetic mutation or genetic problem. And this has been the problem in every disease. In cancer, they were able to overcome this by having access to tumor tissue every time they do a treatment, and they did genetic sequences, genetic analysis, identified targets for the gene therapy. So that is very important. And in epilepsy, over the last 10 years, we've been able to use the tissue that was resected from patients with epilepsy and to sequence this tissue and to identify more specific mutations, what we call somatic mutations only present in that tissue, that are now the subject of some of our gene therapy trial design. So the second barrier is, as I mentioned, it's a technical barrier. And this technical barrier is based on the fact that this brain is different from the muscle. The muscle doesn't have a blood-brain barrier around it or a blood-muscle barrier. It doesn't exist. But around that brain, we do have the big barrier that is by design designed to that is assigned, or its main role is to shut down some molecules from crossing to the brain. So that very blood-brain barrier that we have will prevent us from giving intravenous treatment, for example, unless we find ways to temporarily and hopefully in a regional manner to shut down or disrupt this barrier for 1 or 2 hours. So for this, there are now trials in design that would allow identify the focus in the brain and then use what we call low intensity focus ultrasound, LIFU, and then to shut down the blood-brain barrier for an hour or so and administer a treatment, antisense oligonucleotides, for example, against a particular gene through the vein. The second barrier is based on the blood-brain barrier. So the second option here for us will be to administer the medication or the gene therapy through a probe. Now, this is feasible, and that is there is a trial now ongoing in the United States for gene therapy of mesial temporal lobe epilepsy using a virus vector to administer an antisense against a receptor, which is the cholic acid receptor in patients with hippocampal sclerosis. So the focal administration of the gene therapy is possible, but it's possible you have to breach that blood-brain barrier through a probe that is there. So the bottom line here, if we are going to have any future or we're going to continue to improve or transform epilepsy treatment from treating with less non-specific medication to more specific targeted treatments, we need to understand the genetic mutations and genetic causes of the disease. I think we made major inroads as a proof of concept over the last 10 years, and there is much more to learn. But I'm so optimistic that I tell you, 5 to 10 years from now, if we sit and talk again about epilepsy, where we are, we're going to talk probably the bulk of what we're going to say will be about gene therapy and what is the newest kid on the block rather than, oh, can we do it or not?